The other thing what's causing myopia and what's the progression supposed to look like? And why do we even need to intervene in the first place? This is all important information that we need to share with the parent. So is it lifestyle? Is it genetics? Is it somebody's fault? Is it by accident? You know, these are all things that parents will be asking. And of course, the answer to all of those things is kind of like yes. It's any combination of all those things. But it is important to establish sort of the family history. So if one parent is myopic, chances are there's a 1.5 times chance that child is going to be more myopic compared to a parent who does, a child who does not have myopic parents. And if there's 2 parents that are myopic, then it's 3 times as much. And this helps, you know, I don't know how the kind of conversations you guys are having with parents, but these days especially, parents are concerned. It's like, is it just too much iPhone? Is it too much tablet? And yeah, sure, that's part of it, but it is important to take some of the blame off of yourself as a parent and some of the blame off of the child a little bit to understand there's a genetic component to this as well. But of course, the tablet is an issue. There's a reason we're seeing an increase in prevalence in myopia across the world. And so recommending time outdoors is very, very important. And this is, again, just important so the parents understand the scope of what we're trying to do. We're not simply giving you a pair of glasses to put on your child and send you home. We're trying to prescribe a holistic approach to correcting the myopia and managing the myopia over time. So time outdoors is important. So the studies will show, of course, that more time spent outdoors reduces myopic progression over time. And there is a plateau eventually, but let's just use 1 hour as an example. 1 hour of time spent outdoors can reduce progression by 45% of the risk of progression. But that's important also to consider when we're implementing that. Now, it's important for all children, but it's more effective in younger children. Children who are 5 or 6 years old will have a larger benefit than a child who's 11 or 12 years old in that time spent outdoors. Also, it's more effective in kids who are less myopic. So if you have a child who's emetropic but is showing myopic progression, that time outdoors is going to be more important for that child than a child who's already myopic, maybe 10 or 12 years old. Now, still tell them to go outside, this might not be as effective. But it's just implementing these strategies as early as we can be very beneficial. That's kind of the thing that we want to keep harping on is the earlier we implement, the better. Right? We had this picture up of the lady stopping the car. And I use this analogy, I love this analogy for a couple of different reasons. One, the thing that Sheena already mentioned, it's easier to stop earlier on, before stop a moving object before it gains too much momentum. Stop the myopia before it gains too much momentum. It's much easier to slow it down at an early stage. But the other thing that I use this analogy for is we'll implement something like the glasses, for example, and I'll have patients come back. We'll talk about the return schedule, follow-up schedule a little bit more in a minute. But let's say they come back at 3 months. They might show a quarter diopter increase. They come up at 6 months, they show another quarter diopter increase. And parents are saying, well, I thought it's supposed to stop. And I said, well, think about if you're stopping a moving car, it's rolling really slowly. Unless you're Superman or Superwoman, you have to stop it dead, right? Realistically, you're going to have to absorb that a little bit, and then we'll be able to slow it down. And that's how I like to use that analogy with the myopia progression as well. We'll usually see a little bit of progression for 6 months, and then we'll see things sort of stabilize and level up. Almost, I wouldn't say almost every time, but a very high percentage of the time, that's what I see, whether I'm doing atropine or Hoya lens or contact lens, that's generally the way that I would see things progressing. So I like to use this analogy for a couple of different reasons. But again, implementing solutions early on is the key here. That is really the most important thing to stress to our patients and our parents. And on this little chart, it's a pretty simple chart here. There's 2 lines. The blue line represents a child whose myopia onset was at 7 years old, and the red line is a child whose onset was at 11 years old. So the earlier onset child, by the age of 16, is likely to progress to a -6. Whereas the one who starts, the myopia onset was later, at the same age will only progress to about a -3. And you'll say, okay, well, they've been myopic longer, of course they're going to progress further. But if we can implement a myopic strategy, myopia management strategy right here, they'll end up pretty much at the same place as this child. And that's an important difference. -6 is what we would consider highly myopic. I think even -5, depends on where you look. And once we get into that highly myopic category, there's a lot of increase in risk for health consequences as well, ocular health risks. And I don't like to harp on this with parents, but I think it's very important. Again, if I'm speaking to a parent, I will have talked about what causes myopia? Why is this happening? What is the progression and how can we stop it? Also, if we don't stop it, there's a risk of these other things potentially happening. I don't want to spend too much time on it. I don't want to be a fear monger and make sales in the optical because parents are running, thinking that their children are going to go blind. But it is important to let them know the child that is highly myopic, so -5 or higher, has a 40 times increase in risk of developing maculopathy compared to an emmetropic child. A child that is highly myopic has a 20 times increased risk of developing retinal detachment compared to an emmetropic child. A highly myopic child has a chance of 5 times greater chance of developing cataracts than an emmetropic child. So these are all important things to know that we can kind of blend into the conversation with our patients and our parents because it's not just a refractive condition, right? Again, we're changing our mindset to think of myopia as an actual ocular disease that we need to treat and manage as if it were glaucoma, as if it were dry eye, and not just putting a pair of glasses on a patient. So once we've had this conversation, hopefully not overloaded the parent with all this information, it's important to have a two-way conversation, right? It's not just a one-way, like, let me tell you everything you need to know. Let's have a two-way conversation. Does the parent have questions? How do we establish what is the best solution for this child that's in front of us right now? And that comes with the questions that we ask, of course. So asking the parent, with the information that we have, what solution do you think will suit your child the best? What is their lifestyle? What are their habits? What is their hygiene like? Does your child like to wear glasses or not? If they do, if they're comfortable wearing glasses, then great. Spectacle lens option is a good option for us in Canada. Not to rub it in, but maybe not yet here. But does your child not like wearing glasses? Perhaps a contact lens option is better. Or if they don't need to wear glasses or don't like to wear glasses and they're very low myope or pre-myopic, then we can look at atropine as the option. If your child does a lot of activities, a lot of sports, and if their prescription allows, then maybe we need to put them into contact lenses. Or perhaps consider ortho-K, right? If soft contacts can't cover that prescription and you really don't want your kid wearing glasses during the day, then perhaps we look at ortho-K. But having that two-way conversation and establishing what is the best solution for this individual child that's in front of you and not applying some kind of cookie-cutter approach is very, very important. So then, we've had that conversation, we've had that two-way conversation. I don't have a piece of paper. Okay, I'm going to hand you this little pamphlet. We've decided which is the best solution for the parent and the patient. The next thing we need to do is the handoff. And we just did a little panel discussion and talk about retail strategies and how we can make sure we keep our optical and our retail strong, how we can make sure we shield ourselves from online and other kinds of competition. And one of the key things that kept coming up over and over was the handoff. You come out of the exam room, what do you do next? And I imagine many of us are good at this, and most of us are good at this, but it's just important to reiterate the importance of this. The conversation that happens and the transition that happens between the doctor and the optician and whoever else is in the optical. So Sheena and I are going to do a quick role play of the conversation that we have. We're basically just going to say the words that I would naturally just say to my optician, and the patient and the parent will be standing right in front of us. Okay. So we come out of the exam room. I would introduce the parent. Hello, Mr. Smith. Oh, not hello, we've just been talking. Mr. Smith, this is Sheena. She is our optician. She is our optical expert. She is going to be able to help you fill this prescription that we just talked about and help continue the care for your child and provide the solutions that we talked about. Sheena, I've been speaking with Mr. Smith about Mr. Smith's child, Little Smith, about Little Smith's progression in myopia. Last year he was at -1, this year he's at -2. I think it's very important for us to implement some kind of myopia management strategy. In particular, for this child we've talked about implementing the Hoya MyoSmart lens that's going to help slow down the progression of myopia. So Mr. Smith, Sheena will be able to take it from here, and here's the prescription, Sheena. And if you need anything else, let me know. And I'll see Little Smith back in 3 months for their follow-up.
Thank you, Dr. Sion. Wow, that is a pretty big progression in myopia, but don't worry, we have some great solutions. So let's come into the optical, take a look at some great eyewear and solutions that are going to be compatible to take care of Little Smith.
I gotta come up with a better name. Sorry.
As I mentioned before, I kind of have a unique perspective on this because every patient that is coming into my practice is coming into the practice with a prescription in hand. And oftentimes, more often